Your YouTube link is still not visible.
Sir, there will be a lag of 2 to 3 minutes, sir. From our server, it goes to YouTube server. So there will be a gap of 2 to 3 minutes on YouTube and live session.
So tell me when to start.
Sorry, sir.
So just tell me when to start. I'll
Sir, we are live now. Good to go.
Good to go. Okay. Am I audible?
Yes, you are audible.
Yes.
So hello everybody. We are here today for the discussion regarding complicated UTI. I'm Dr. Kamlesh Kunjan. I'll introduce you all the speakers who will speak over the dilemma and solutions regarding complicated UTI. So good evening everybody. First of all, we have the speakers, Dr. Vijay from AIIMS Jodhpur, then Dr. Deepak from AIIMS Raipur, Dr. Shivcharan Navadia from AIIMS Rishikesh, myself from AIIMS Patna, and Dr. Kamaljeet Singh Kaura from AIIMS Bhatinda. Dr. Himanshu Pandey was also in the panel, but unfortunately, due to some personal reason, he is not available. So the dilemma and solutions will be presented in different headings. Dr. Vijay will be the first one to present and will moderate the entire session. Over to Dr. Vijay.
Thank you, Dr. Kamlesh, for the opportunity. And I'm just sharing my screen. Okay, so my screen is visible?
Yeah.
Yes.
Okay. So starting off the proceedings today, the theme of today's webinar is complicated UTI, dilemmas and solutions. So obviously the first step in the discussion of a problem is to define the problem and to identify the problem. So that is the title of my webinar, Complicated UTI, Definition and Magnitude of the Problem. So before going to complicated UTI, let's just in brief see what is uncomplicated. Which UTI you call uncomplicated? It's very simple. UTI which occurs in a otherwise healthy host who is not immunocompromised and who has a structurally normal urinary tract as well as a functionally normal urinary tract, and usual pathogens are implicated of known virulence and sensitivity. So this is uncomplicated UTI, and this scenario is usually seen in young females where there is a cystitis. Otherwise, the urinary tract is normal, and usually the infection is by E. coli with sensitive organisms. All the fluoroquinolones are also acting on it, and the second and third generation cephalosporins. So now you can easily deduce the complicated UTI, what it will mean, where the host is not healthy. For example, in immunosuppressed patients or diabetes, where there is increased susceptibility to infections, either this or in a patient with a structurally abnormal urinary tract, okay? Or in a functionally abnormal urinary tract, I will be discussing this, or a patient having a pathogen which is highly virulent like pseudomonas or has a multi-drug resistant pattern. So any of these things can lead to complicated UTI. So just going into brief, what are the host factors which may lead to a complicated UTI? Diabetic is the number one cause in our clinical scenario, and we have to be very careful while dealing with UTI in diabetic patients. Any immunocompromised status like HIV, any admitted patient is also a risk factor. So because usually admitted patients have catheters or otherwise they are not able to empty their bladders or any other reason, they may be predisposed to UTI. Male gender usually will have complicating anatomical conditions, and that will be cause of a UTI which is not getting treated properly. Then pregnancy, due to the various hormones in pregnancy and the pressure effect of gravid uterus, there is dilation of the upper tract, especially on the right side. So this is also a complicating factor. Then elderly patients have multiple comorbidities. Usually they are diabetic, hypertensive, and their immune systems are also not that active. Then any indwelling catheter or a stent or PCN. This is also a common scenario. Any patient with a periurethral catheter or a DJ stent or PCN in situ, if he develops infection, then it is a complicated UTI. Any history of instrumentation, including urodynamics or retrograde urethrophy or micturating cystourethrophy. UTI occurring after that is considered complicated. And then if the symptoms last for more than 7 days, it means the organism has developed either resistance or the proper antibiotics are not being given. So this is also a complicated UTI. Then structural abnormalities, I think we all know, right from starting from the kidney till the urethra, there can be a lot of structural abnormalities like pelviureteric junction obstruction or a calyceal diverticulum. There can be stones or a ureteric stricture, prostatic enlargement in the lower tract or vesicoureteric reflux or urethral stricture or a bladder diverticulum. So all these structural abnormalities, they cause retention of urine or they present a obstruction to the outflow of urine, leading to urinary stasis and colonization and infection by pathogenic organisms. Then some functional abnormalities also, where the pathology is outside the KUB region, but it still leads to decrease in the renal concentrating ability, like neurogenic or non-neurogenic lower tract dysfunction. So secondarily, the kidney, ureter, bladder unit is affected, and this leads to UTIs because of inadequate emptying or reflux into the upper tract. Fourth reason of complicated UTI is pathogen related. So if there are high virulence organisms in a particular area due to rampant antibiotic usage, the ESBL producing bacteria rise in number, and these are more virulent because the common antibiotics don't act on them. And even intrinsically, some organisms like Pseudomonas and Serratia, they are having high virulence and intrinsic resistance to many antibiotics. So these unusual pathogens are also considered to cause complicated UTI. Previous antimicrobial use, like I said, is a risk factor for complicated UTI. So some two other terms I will like to discuss regarding complicated UTI. These are unresolved infection and the recurrent infection. So these are also the presenting signs of a complicated UTI. So unresolved infection means where you have given the sensitive antibiotic for the required period of time, but the UTI has not been eliminated. Okay, so that means resistance has emerged, and this unresolved UTI is also considered complicated UTI. Also, there can be recurrent infections where the UTI is treated, but then it again comes back. Okay, so that is also a reason of complicated UTI. This recurrent infection can be due to either reinfection by a new organism or due to bacterial persistence within a nidus in the lower or upper tracts. For example, a stone or a calyceal diverticulum or a bladder diverticulum, it may act as a harbinger of organisms which are not acted by the antibiotics, and once they are discontinued, these bacteria again cause UTI from their nidus. So any unresolved or recurrent UTI should prompt the search for a cause of complicated UTI. So this is the brief definition and classification. And why is it important? Why should we know? Not only the urologists, but also the general physicians and surgeons working in the community, they should know about this. These are some statistics. Why is it so difficult? Catheter associated UTI is the most common nosocomial infection. I think we know all this from the MBBS days, and it's an important cause of nosocomial UTI. And sorry. Each catheter associated UTI costs US dollars 589 to 758 in treatment. So this is in Indian rupees. You can easily imagine it runs into lakhs of rupees. And if that nosocomial UTI requires ICU care, almost 2000 US dollars are spent in treating one person. Regarding the Indian studies, in India also it is the same. Spectrum everywhere is the same. In a study in AIIMS by Shashikant et al., there was a 3.3 prevalence by colony count of UTI in pregnant females. But there was 30% prevalence of UTI by symptoms. So here one more problem is highlighted that symptomatically and clinically one may feel it is UTI, but the colonies are not growing. The UTI is not being documented either due to improper collection or due to not sending the sample. Then this is a study from BJMC Ahmedabad, which was published in Journal of Family Medicine in 2019, where the UTI presenting to a tertiary level hospital was evaluated. Okay, so these UTI were not treated at a lower level hospital and they had to be referred. And in this series of referral UTIs, they found that E. coli comprised only 36% of the isolates. So usually we are thought that 80% of UTIs are caused by E. coli. But once you see a UTI in a hospital setting, you cannot be very sure that it is due to E. coli. It can be due to more resistant organisms. Here you can see that E. coli, only 36% UTIs were caused by it. And that also the Ciplox sensitivity was only 27%. We all assume that fluoroquinolones are the drugs of choice for treating UTI, but you can see here in hospital settings, this is not the case. Surprisingly, Candida caused 18% of the UTIs. This may be due to the immunocompromised status of patients or any indwelling catheters or stents. Klebsiella also comprised 18% of patients with a very low sensitivity to fluoroquinolones. This is another study, an old study from MS Ramaya Hospital, Bengaluru, where they studied culture positive urinary tract infection caused by catheter associated UTI, and found that 42% was by ESBL producing organisms and 74% had resistance to fluoroquinolones. So this is a common pattern we see that when we are seeing a patient of UTI in a hospital setting or in a relatively larger setting, we have to be aware of multi-drug resistant organisms and unusual organisms. This again later on study from Global Hospitals Chennai. They studied all community acquired UTIs in the time span of 2012 to 2013 and found that 75% had a complicated UTI, either due to host factors or anatomical or functional factors. So basically this underscores the need of identifying complicated UTI early enough and instituting prompt treatment. So the summary is that any UTI should be evaluated for factors causing complicated UTI. So now what I feel is that seeing a UTI and writing empiric antibiotics, those days are gone. Not only you have to document the culture and sensitivity, but you also have to search for factors causing complicated UTI. As you can see that a high percentage of UTIs are associated with complicating factors. And if they are not resolved fully, then there will be recurrent infections causing morbidity. So correct evaluation and treatment is important to prevent morbidity, and even sometimes patient may go into sepsis and even have a fatal outcome. So this has to be prevented. So not only cultures, but I think a preliminary search for any anatomical functional abnormalities, at least an ultrasound KUB region is important to document the normality of urinary tract. And then lastly, I would like to just say that we have to take care of our cognitive biases. Basically, we have a blind spot for the obvious. So in this era of COVID, even though we all know that precautions are very effective, but I think a lot of people now, especially the public, have stopped taking precautions. And most of us seem vaccine is easier than the precautions, whereas the reverse is true. And also in case of UTI, we surgeons and urologists, for us surgery is more important, but we have to remember this complicated UTI is condition with far more prevalence, and economic burden. So we cannot forget this. We have to treat this and we have to be alert to this. So, thank you. This is my initial presentation highlighting the importance of complicated UTI. Okay. So now I will invite Dr. Deepak Biswal. Dr. Deepak Biswal is assistant of AIIMS Raipur. Now he will take the discussion forward and now he will tell us the evaluation and pharmacologic management of complicated UTI.
Yeah, thanks, Vijay. Good evening, everybody. As Vijay told the classification, I will not repeat the definition of complicated UTI. Basically, definition of uncomplicated UTI is easy. So anything that is no uncomplicated is complicated. So most commonly we in OPD, the patients comes with lower urinary tract symptoms like dysuria, frequency, urgency, and it can associated with suprapubic pain. So we stamp it as UTI. But in female, we should always take history of is there any presence of vaginal irritation or discharge. So if those are present, we should always think of vaginitis by STI or any atrophic vaginitis due to estrogen deficiency in case of postmenopausal women. So the acute pyelonephritis is also similar. The patient comes with acute flank pain, fever, and it can associated with chills and other constitutional symptoms. It may or may not associated with lower urinary tract symptom. So these symptoms shows either the patient is having acute cystitis or pyelonephritis. So as Vijay told, you should always, before prescribing any antibiotic, you take focus history and medical physical examination to chunk out if there is any complicating factor which can cause further problem in treatment in this patient. But in some special patients like elderly or catheter associated UTI or in spinal cord injured patient, those will be talked by a later speaker. I will leave those. They can present with atypical symptoms. So in any patient presenting with symptoms suggestive of UTI, we should ask for duration of symptoms, any recent use of antibiotic or current use of antibiotics. Because if we miss, we can prescribe drug which they may be already resistant, the pathogen may be already resistant to the drugs. Any recent hospitalization is a predisposing factor for complicated UTI. As Vijay told, pregnancy, diabetes, and immunosuppression are there is increased risk of complicated UTI. And we should elicit any history of past urologic abnormality or any body dysfunction in the childhood or any surgery of the spine, which can we think there can be any neurogenic bladder. And these two things are also important. If any female, young female, there is multiple sexual partners or recent change in sexual partners, or her mother has UTI, history of UTI. So most probably these are the uncomplicated UTI. So differential diagnosis, as we told, not all symptoms of dysuria, frequency, urgency are UTI. We should keep in mind that can be STI, both male and female, urothelial malignancies, there can be stone. And in our region, it is uncommon, but we should also keep in mind the thing about interstitial cystitis or painful bladder syndrome. So in focus physical examination, we should see for bladder distension, or any flank tenderness. In female, in young female, we should see for vaginal discharge or urethral discharge to rule out STI. And in elderly postmenopausal female, we should see about the condition of the vaginal mucosa and pelvic organ prolapse. These two things can also produce symptoms of dysuria urgency and frequency. And there may not be UTI in these patients. In male, we should check external genitalia for urethral stricture and DRE for evaluation of prostate. Next, coming to investigation. If we are thinking that the infection is uncomplicated, we can skip this. We can give antibiotic, and we can review after 3 to 5 days. But if we think the patient may have complicated UTI, we should take urine sample for urine analysis. So I will keep emphasis on the sampling methods. The midstream sample is commonly used, but if the patient is very old and heavy and there is vaginal atrophy or there is significant pelvic organ prolapse, she or he may not give proper midstream sample, and the sample will be contaminated and the result will be fallacious. If you think you prefer better to go for a single catheterized specimen, put a catheter, take sample, remove the catheter. And in a recent study, it is shown that by this method, they have prevented false positive rate of about 50% and prevented 50% inappropriate antimicrobial to those patients. So we should bear in this mind. Suprapubic aspiration is now not commonly used, and a recent study shows that it resembles the midstream sample. And in case in patients with catheter-associated UTI, if you are suspecting, remove the old catheter, put a new catheter under aseptic precaution, and take a sample. And in case of urinary diversion, take stoma intubation and take the sample. So urine dipstick is not commonly used, and also there is very low specificity and sensitivity, and so it should not replace the conventional urine microscopy. Urine microscopy we see for leukocytes, for pyuria, and RBCs for hematuria. And epithelial cell, if there is, in the microscopy we see many epithelial cell, the sample is contaminated, we should discard and resample him or her. And bacteria is not very significant in urine microscopy, because if bacteria is absent, this does not rule out UTI, because that can be due to diluted urine. And this thing is very common. We see generally in patient referred to us, patient is having pyuria, and he was given multiple doses of antibiotic. We should know the pyuria can cause, apart from UTI, by GU tuberculosis, stone, any foreign body, or other renal condition. But if there is absence of pyuria but positive culture, then it can be asymptomatic bacteria. But before that, it is published, and recent guidelines told that you should try to take a catheterized sample before stamping the patient as asymptomatic bacteria. So next is urine culture. Here I will give the difference between significant bacteria. In a symptomatic patient, midstream sample, if more than 100 colony forming unit pathogen is there, then we should start antibiotic. But for asymptomatic bacteria, the definition is different. For a midstream sample, in female, 2 samples are required of more than 10 to the power 5 colony forming unit. For male, single sample is required. And in catheterized sample, in both male and female, single specimen of showing single strain of more than 100 colony forming unit pathogen is significant. So in complicated UTI, as Dr. Vijay told, you expect that the pathogen are multi-drug resistant. So this should be bear in mind before prescribing antibacterial. The imaging study, during initial evaluation of a patient, if there is history of any stone or any genitourinary surgery or any neurogenic bladder, you are thinking there can be urinary tract obstruction. So image the patient early. In case of diabetes, there can be emphysematous pyelonephritis or papillary necrosis, which can cause urinary tract obstruction. So early image should be done. In cystic kidney disease, there can be renal abscess or perirenal abscess. Early imaging should be done. But during management of an uncomplicated UTI, if patient developed febrile UTI or there is poor response, clinical response of antibiotics after five days, or there is clinical deterioration, you should image to rule out any complication. There can be renal abscess, there can be perirenal abscess, there can be pyelonephritis of a uncomplicated cystitis. Or during evaluation, you find that there is fungus or proteus in the urine. So there can be stone or other obstruction in the urinary tract. So you should image. And if patient is having either resistant infection to the antibiotic or recurrent infections within 4 weeks of symptomatic relief, then you should think of bacterial persistent. There is some nidus of bacteria which is resistant to the conventional antibiotic therapy. So we should think, and those are surgically there. Those are maybe surgically correctable. So already this is mentioned by Dr. Vijay. We should these are diagnosed in imaging and surgically corrected. So for image for evaluation of bacterial persistent, for any cystoscopy is required for any urethral diverticulum, bladder diverticulum, or pelvic organ prolapse or cystocele. USG is initial investigation, and MRI and USG is done in pregnancy. VCUG for any reflux, RGU for any urethral stricture, and rest other thing, CT scan is a better modality for anatomical delineation. So the principles of UTI management. Complicated UTI, there is the challenges are there is high risk of treatment failure. Those can progress to serious complication, and there is development of antibiotic resistance during the treatment. So the management strategy is first correct the urological anatomical abnormality or underlying comorbid condition first, along with optimal antibiotic therapy. So antibiotic therapy depends on the severity of illness at the presentation, local resistant pattern, but unfortunately in India, mostly it is not, the local antibiogram is not available, and the host factor. The drug therapy can be different for pregnancy in CKD patients, or if patient is having previous allergy. So if local antibiogram is not known, which is most common, this I want to highlight. In recent guidelines, they told if local antibiogram is known, then we should start the empirical therapy. If it is not known, start the empirical therapy, but before that, give a single dose of long-acting parenteral antiviral. That is, give a single dose of either third generation cephalosporin or a fluoroquinolone. Then after that, we can start the empirical oral therapy. If patient is, we are planning for outpatient treatment. Pharmacological agent, everyone know, I will skip. And this is the thing. Antimicrobial stewardship. This is very important. During uncomplicated UTI treatment, inappropriate use of antimicrobial can complicate it by producing multi-drug resistant pathogens. So it is already known the fact and repeatedly told by various persons. WHO also told repeatedly. So I will not go. So the essence of antimicrobial stewardship is narrow spectrum, evidence-based, appropriate dose and minimum duration, and monotherapy as if possible. So asymptomatic bacteria. The thing is, this is not a complicated UTI, but it will be talked later by the speaker. Do not screen for asymptomatic bacteria or treat except pregnancy and in patient undergoing any urological intervention. Now the treatment for I am telling treatment of uncomplicated cystitis because we should use antibiotic properly for them to prevent the complicated UTI. The first line in a female which is non-pregnant and healthy is phosphomycin 3 gram single dose, or you can give nitrofurantoin BD for 5 days. And but in third trimester, we should avoid nitrofurantoin. We should give cephalosporin in case of pregnancy. In men, the thing is in female, the urinary concentration of the antimicrobial is important for the treatment eradication. For the microbial eradication, for men, we should give the antibiotic which penetrates the prostate because in most UTI in male are complicated and involves prostates. So previously we commonly use ciprofloxacin, but nowadays two things are important. One is resistant to ciprofloxacin, fluoroquinolone is very much high in our region, and there is concern of side effect. The recent EAU guideline has given a warning that you should avoid ciprofloxacin. And also we commonly seen in our culture report that patient is resistant to fluoroquinolone, but he is sensitive to cotrimoxazole and nitrofurantoin. But in male, we should not give nitrofurantoin. We should first we should give cotrimoxazole. But the thing is, there is a risk of rashes and Stevens-Johnson syndrome, although those are very rare. Alternatively, you can give ciprofloxacin if not contraindicated. In case of uncomplicated pyelonephritis, first line is also fluoroquinolone. We can give ciprofloxacin, levofloxacin as oral therapy, or cotrimoxazole we can give. But the thing is, if we give cotrimoxazole, then give a single shot of ceftriaxone, that is third generation cephalosporin first, then start with cotrimoxazole. If the patient has systemic features, then require hospitalization, then parenteral therapy of fluoroquinolones or third generation cephalosporin is required. In case of multi-drug resistant, we can start piperacillin tazobactam, and in case of resistant to them, we can start imipenem or meropenem, those carbapenems along with aminoglycosides. So complicated, those are the things which are non-complicated. I told because you should judiciously use in non-complicated UTI to prevent complicated UTI. In complicated UTI, as already told, the commonly the pathogen is multi-drug resistant. If patient is having systemic symptom, start with intravenous antibiotic. Of better to start extended spectrum antibiotic like piperacillin tazobactam along with aminoglycoside or a third generation cephalosporins. The duration of antimicrobial therapy is 7 to 14 days. In female, they are telling 7 days. In male, most commonly prostatitis is involved. Is there along with UTI, so 14 days is recommended according to recent guidelines. But the thing is, you should also clear the urological anatomical factor correction and the comorbidity condition correction. And the antibiotic therapy duration should be at least afebrile for at least 48 hours to stop the antibiotic. So multi-drug resistant pathogen, this is a big problem now. And for ESBL, we have extended spectrum antibiotic like piperacillin tazobactam. And now the thing is, we are commonly seeing the carbapenem resistant enterobacterial species. So they are resistant to all third generation cephalosporins. They are resistant to meropenem or imipenem also. And there is the problem. The only option we have the tigecycline and colistin. And those are also, the colistin also we are seeing emerging resistant. So thank you. I will ask the next speaker to continue the surgical management of complicated UTI.
Thank you, Dr. Deepak Biswal, for a comprehensive summary of the evaluation and pharmacologic management of complicated UTI. And now I will call upon Dr. Shiv Charan Navaria, who is assistant professor in AIIMS Rishikesh, and he will be speaking about the surgical management of complicated UTI. So Dr. Shiv, please.
Hello.
Yeah, Dr. Shiv, can you please share your screen? Okay.
Yeah. Is it visible?
Please go ahead.
Okay. Good evening, all. I will speak on the surgical management of complicated UTI. So, a great tribute to this man who revolutionized the management of infection in the history of medicine. Complicated UTI needs special attention as they are associated with treatment failure, repeat infections, significant morbidity, and mortality with poor outcomes. Complicated UTI has four aspects to deal with: structural abnormalities, metabolic or hormonal abnormalities, impaired host responses, or unusual pathogens. The steps of management includes resuscitation and stabilization of patient with IV fluid, antibiotic, and inotrope if needed, and the diagnosis of underlying abnormalities or complicating factors. So for that, we need imaging to exclude complications such as abscess, calculi, gas, obstructive uropathy, and hydronephrosis, or any underlying abnormal anatomy. And then after identifying the anatomical abnormality, we have to correct the abnormality. In older days, emergency surgical exploration with nephrectomy was the standard of care, but since the advent of intravenous antibiotics along with minimally invasive methods of urinary diversion, it has drastically reduced the morbidity and complication rates. There are many correctable urological abnormalities that cause bacterial persistence, including stones, ureter duplications, foreign bodies, urinary medullary kidneys, refluxing, non-refluxing ureters, infected communicating cysts, or papillary necrosis. Coming to the emphysematous pyelonephritis, emphysematous pyelonephritis is a necrotizing parenchymal infection, and it should be treated based on the clinical condition of the patient and the class of the EPN. Initial management of EPN involves resuscitation, antibiotic treatment, control of diabetes, and grade 1 and 2 EPN needs can be treated successfully with the conservative treatment, but grade 3 and 4 warranted further procedures either in the form of drain placement, in the DJ stenting, or in advanced cases it may need nephrectomy. Stenting and percutaneous drainage is the most appropriate management strategy for most of the patients. Emergency nephrectomy is advised for patients not responding to above treatment with extensive renal destruction. This is one of our case. This is one of our case. We can see there is extensive gas distribution in the EPN extending to the lower limb, which was managed with minimally invasive intervention, including PCN plus DJ stenting. And we can show in the follow-up imaging that the resolution of the gas in this patient. Next, renal and perirenal abscess management. The open surgical drainage, debridement, and nephrectomy was once thought widely used, but nowadays percutaneous techniques with or open surgical approach is reserved for more severe or refractory cases. Percutaneous drainage plus parenteral antibiotics is indicated as the initial treatment of abscess 3 to 5 centimeters size. For the treatment of renal abscess, if it's less than 3 centimeters, then conservative treatment with antimicrobial therapy is sufficient. 3 to 5 centimeter clinically stable patient, antimicrobial therapy, and if not responding, then aspiration should be done. If more than 5 centimeter size, then percutaneous drainage should be done with help of pictal catheter. A drainage procedure should be considered when there is large abscess and no clinical improvement occurs after 48 to 72 hours of appropriate antibiotic therapy. Drainage via the percutaneously placed tube continue at least until the patient is afebrile and stable, and then until the drain output should be minimal. Pyelonephritis usually respond within 3 days, but if it's not responding, then perinephric abscess should be suspected. It should be considered when the UTI do not respond promptly to the antibiotics. Prompt diagnosis is the key for the management of the perinephric abscess, because up to 25 to 30% patients of perinephric abscess diagnosed on the autopsy. The advantage of percutaneous abscess drainage includes it is simple, rapidly performed, feasibility of bedside performance, its safety, avoidance of anesthesia, and it has all documented efficacy. Indications for renal abscess drainage depends on the size of the abscess, whereas drainage is generally indicated for perinephric abscess of all sizes. So it should be considered that renal abscess we can manage conservatively, but for the perinephric abscess we need high index of suspicion and all size should be drained with via the pictal catheter. Indications to intervene aggressively includes persistent of infection, unresponsive to antibiotics, and non-aspirable thick collection, impending sepsis, or ongoing hemodynamic instability. If surgical exploration is indicated, the abscess should be explored and drained. Copious irrigation of the infected renal fossa with antibiotic irrigation should be done with placement of perineal drain. Nephrectomy should be reserved in the patients with diffusely damaged renal parenchyma or in patients who are septic or require urgent intervention for the survival. This is one of our case we managed with placement of wide bore pictal catheter 14 French. First case is renal abscess. Second case is perirenal abscess with obstructive renal stone, which was managed with placement of PCN tube. Next one is infected hydronephrosis or pyonephrosis. Infected hydronephrosis is the bacterial infection of the hydronephrotic kidney. Pyonephrosis is infected hydronephrosis plus suppurative destruction of the renal parenchyma with or without loss of renal function. The clinical presentation is similar to the complicated UTI. And urinary tract obstruction when associated with pyelonephritis, then it's pus under the pressure. So these patients are more prone to deteriorate rapidly and become septic. Thus, early recognition and treatment of acute infection of the kidney, especially pyonephrosis in the case of obstruction, are paramount in importance. And the treatment of choice is decompression, either by the placement of digestant or PCN tube. Retrograde decompression includes digestant, and it has its advantage because in the stable patients or hemodynamic stable patient, digestant is preferred, but intravenous antibiotics must be given prior to stenting. Disadvantage of placement of digestant is that it's a small caliber urinary drainage catheter than percutaneous access, and there is increased irritative urinary symptoms are noted in post-operative period, and there are pylovenous, pylolymphatic, and pylosinus backflow of infected urine. So there are high chances of sepsis because of retrograde manipulation. So placement of a stent may be challenging in cases of sick patient or obstructed and edematous ureter. Antegrade decompression is another way via the placement of pictal catheter, and it is preferred in a patient who is in sepsis with who needs urgent decompression and who has thick pleural content and when retrograde instrumentation is not successful. Advantages are there that it allows drainage of infected renal unit with minimal trauma and minimal risk to the patient. It avoids additional risk of anesthesia and integrate radiographic studies we can do in follow-up period for the planning of the definitive management. It allows administration of the medication directly to the collecting system if we need, and stones may be sometimes dissolved with chemical solutions, and it allows the integrated treatment of the obstructing stones, and if we need further PCNL, then this tract can be used for definitive management. The disadvantage of nephrostomy includes there is difficulty in placing the tube in some patients because of body habitus, and if there is not much dilated of system, then localization of the hydronephros is difficult with the ultrasonography. And there is possibility of renal trauma and higher chance of bleeding and colonic injuries. Although there is no clear guidelines regarding the optimal option for the urinary diversion, but currently retrograde divulge stenting and ultrasound guided PCN tube insertion are the most widely used techniques. Both are associated with variable technical success, complication rates, availability, and quality of life issues. Retrograde implantation of digestant is associated with septicemia, irritative symptoms, forgotten digestants, and high failure rate. And when failure is there, then ultimately it requires percutaneous nephrostomy insertion. So on the other hand, percutaneous nephrostomy is associated with complications like bleeding, septicemia, tube blockage, and accidental tube dislodgement. Moreover, PCN also requires an extra care of external urine collecting bag. The need of nephrectomy after percutaneous nephrostomy drainage and antibiotic treatment includes when it is non-responsive to the therapy and there is progression of the disease and non-functioning kidney after the stabilization of the disease. These are the some of our patients with specimens. First patient was pyonephrotic kidney, secondary to obstructive calculus. Then we have done simple nephrectomy. Second patient was also having obstructive stone and PCN was placed, but it was not responding because of thick pus. So we have to do emergency nephrectomy. Third patient was case of stricture of ureter secondary to GOTV, and he was managed with ATT plus nephrectomy. And first case, this is having infected focus on the lower pole of kidney with repeated recurrent infections. So we have to do robotic partial nephrectomy in first case. Second case is having obstructed calyceal diverticula with stone. So in first week, we can see the shape of calyceal diverticula, and the second pic, we have placed the guide wire and then we have given a cut with laser. So the opening was opened and the obstructed calyceal diverticula was drainable. Next is xanthoglomerular pyelonephritis. It is a rare, severe chronic renal infection, and usually it's a non-functioning and large kidney with xanthoma cells. So antimicrobial therapy used to stabilize the patient. Then nephrectomy should be done. If IND done, then chances of nephroperitoneal fistula is there. Laparoscopy is technically difficult in cases of xanthoglomerular pyelonephritis, but feasible. It needs advanced laparoscopic skills in an experienced surgeon. Urological devices can also cause complicated UTI. So these devices can include urethral catheters, ureteric stents, nephrostomy tubes. So they should be changed or removed timely. Urolithiasis can also cause obstruction and can lead to complicated UTI. So they should be first patient should be stabilized by diversion, either by DJ stenting or PCN. Then later on definitive treatment should be done. In complicated UTI in pregnancy associated with obstruction should be dealt as an emergency and should be relieved by ureteric stent placement or percutaneous nephrostomy tube. In the pediatric patients, there can be underlying abnormal anatomical abnormalities, includes posterior urethral wall, which should be fulgurated, vesicular reflex, which should be managed in lower grade of reflex, it should be managed with antibiotic prophylaxis as per guidelines, and in high grade of reflex like grade 5 or bilateral reflex, it should be managed surgically, the implantation of the ureter. Ectopic ureter, megaureters are to be managed as per guidelines. Bladder stone should be removed or any other underlying abnormality should be corrected to treat the complicated UTI. Next one is prostatic abscess. If prostatic abscess is small, then conservative treatment with quinolones or third generation cephalosporins are sufficient, and if it's a abscess is causing fever and not responding to the conservative treatment, then aspiration should be done with low threshold by truss guided aspiration. The transurethral deroofing is indicated for large, multilocated, recurrent or residual abscesses or patients with associated BPH and persistent LUTS. This is one of the patient of prostatic abscess. Left side image is showing on the truss image and right side image is showing on the CT. This patient was managed with truss guided aspiration of the prostatic abscess with quinonols and third generation cephalosporins. Fournier's gangrene is also a idiopathic infection of the scrotal skin, which is potentially life-threatening infection, and prompt diagnosis is important to manage this case. This is one patient we managed by wide debridement of the skin and antimicrobial therapy. Orchiectomy is almost never required because of independent blood supply. Reconstruction was used using the surrounding myocutaneous flaps, and foreigner gangrene has almost around 20% mortality. Next one is periurethral abscess. It occurs secondary to the urethral strictures or catheterization, and symptoms are usually include scrotal swelling, fever, retention, or spontaneous draining of the sinus. So treatment is there. Diversion should be done suprapubically, and drainage of the pus and wound debridement should be done with antibiotic therapy, and later on after RGU, definitive management of the underlying cause should be done. Like in this case, this is managed by us. This case showing pus discharging sinus at the scrotum, and later on we drained this abscess and later on found to have stricture disease, which was managed with BMG arthroplasty. So take home message is that complicated UTI is a serious urological problem with high morbidity and mortality rate. It requires prompt diagnosis and appropriate antibiotics and surgical intervention. Availability of higher antibiotics coupled with minimally invasive intervention has shifted the armamentarium away from the open surgical exploration. Each case to be individualized, sound, timely clinical judgment is the key for better outcomes, and it's always better to be safe than sorry. Thank you all.
Thank you, Dr. Shiv Charan, for a comprehensive presentation on surgical management of complicated UTI. So now I invite Dr. Kamlesh Gunjan, who is Assistant Professor in AIIMS Patna, and he will be talking about management in special populations and the emergence of antibiotic resistance, which is a very difficult topic to deal with. Dr. Kamlesh, please.
Hi, everyone. Good evening.
Yes, Dr. Kamlesh, please share your screen.
Yeah. My screen visible?
Yes, your screen is visible. Please make it full screen.
Yeah. Is it okay now?
Yes.
Yes. Okay. So I'll be presenting regarding the management of a special population and emergence of antibiotic. So because previous speakers has already outlined these things, I'll just briefly say one thing, one or two lines regarding this. What is complicated UTI? So just remember, to define complicated UTI, we will have to consider what is uncomplicated UTI. For all practical purposes, just please understand acute cystitis and acute pyelonephritis without having any abnormalities in the anatomy of the system or any foreign body in the system or any diabetes, hypertension or immunocompromising. So acute pyelonephritis, acute cystitis in a healthy young men and women, in a healthy young women is uncomplicated urinary tract infection. So what is complicated? Everything else is complicated, whether it is immunocompromised situation, whether the anatomy is bad, like pediatric population, when there is stone, when there is diabetes mellitus with infection, chronic kidney disease with infection, HIV, transplant, everything else is complicated. So acute cystitis and acute pyelonephritis, just remember these two conditions in healthy women are uncomplicated. Men always complicated. Just remember. Coming to the brief treatment outlines. Coming to the brief treatment outline, uncomplicated cystitis. What are the drugs we have? Remember, I will not take the name of quinolones. I will not take the name of cephalosporin. In periphery or in most of the district level center, what we see, people are treating with whatever they have. They have piperacillin tazobactam for uncomplicated cystitis also. So please remember, there are only 4 drugs you have to use. Nitrofurantoin for 5 days, nitrofurantoin 100 milligram BD dose for 5 days, phosphomycin single dose for 3 days, pivmesilinam, it's a precursor of mesilinam, a beta lactam antibiotic for 5 days, trimethoprim sulfamethoxazole 3 days only when the resistance pattern in that particular area is less than 20%. So just remember 3 to 5 days therapy for women. Try to have a therapy of 5 to 7 days, preferably 7 days for men as per the recent guidelines. So no problem with this. Coming to the uncomplicated pyelonephritis. Uncomplicated pyelonephritis, again, there are 2 groups of patients, those requiring hospitalization and those who don't require hospitalization. So those requiring hospitalization can be treated on the OPD basis. The duration of treatment is 7 days for quinolones and cephalosporin. So just remember, for cystitis, no quinolones, no cephalosporin. This has, the overuse of these things has led to the antibiotic resistance. Now we have quinolones and cephalosporin. If we use trimethoprim, the duration of treatment has to be 14 days. So 7 days for uncomplicated pyelonephritis who are not requiring hospitalization. Uncomplicated thing which requires hospitalization, a total of 14 days is required. 10 to 14 days depending upon when the patient gets become afebrile. And now who requires hospitalization, we have to give IV antibiotic, and again the options are quinolone and cephalosporin, second and third generation only, not beyond that. Apart from that, we have piperacillin piperacillin tazobactam, ampicillin aminoglycoside, and aminoglycoside alone. But as a first line drug, try to have IV levo, IV cipro, or second or third generation cephalosporin. That's it. Coming to the treatment of complicated UTI. Now, as far as complicated UTI is concerned, the choice of antibiotic remains the same. The only thing is, if you find the bacteria are not responding or they are ESBL, we have make a broader choice. We have to switch to higher classes of antibiotic, but the patient has to be hospitalized. Antibiotics stays the same. The only thing that is present in complicated UTI are the other extra thing, that is either obstruction in some way or other, that is surgical, anatomically not a good renal system or not good urinary system, means there is some obstruction somewhere, or the patient might have a medical condition like diabetes, immunocompromised, HIV, transplant, etc., etc. So just remember 7 to 14 days of antibiotic. Use ESBL inhibitors because complicated UTI are mostly by the resistant strains. More chances of drug resistant infections here. Now let's understand what are these special groups. So special groups are pregnant women, again elderly. Institutionalized means in our countries it is not much common, but still it is there, like old age home, nursing home care, people staying in a group at some shelter homes. So these are the institutionalized people, and they have higher prevalence of infection. Elderly, higher prevalence. Age, sex, and age and sex are important regarding this. Coming to diabetic population, then neurogenic bladder conditions, upper tract or lower element type of disorders, indwelling catheter, HIV, transplant. We will see what we have to do. So let's understand what happens when this patient develops asymptomatic bacteriuria. Everything else has been discussed, so I'll be focusing on this. Asymptomatic bacteriuria, what we can do. What is asymptomatic bacteriuria? It is 10 to the power 5 CFU per ml in one sample for men. So one mid-urethral sample or 2 sample in women, when cultured, will have a growth of 10 to the power 5 without any symptom. If we do a catheterized sampling, only 1 sample is required. So this is asymptomatic bacteriuria. Now, what about pregnant women? Asymptomatic bacteriuria is very much common, fairly common in women. But when it comes to pregnancy, we have to screen it. Anyway, antenatal care will take care of the screening of routine urine and then the culture if the bacteria are found, and then we have to treat it, because the continued bacteriuria might get into complicated urinary tract infection in pregnancy because of decreased immunity at that time, and lead to preterm babies and low birth weight babies. So these are the things. So we have to do short course antibiotic treatment, same 5 days. Young women, you might be seeing a lot of women coming to the OPD that I am having this report repeatedly for 3 years. E. coli is coming. You don't have to treat. It is proven in RCT. No benefit in treating these patients. Doesn't prevent any breakthrough clinically significant symptomatic UTI. So this is important. Coming to the elderly institutionalized patient, we don't have to treat again unless they are symptomatic. They have a very high prevalence of bacteriuria in the range of 25 to 40%, but still if they are asymptomatic, don't treat, because it will not prevent the further clinically symptomatic infection. Diabetic, if it is well controlled, no need to treat. If it is not controlled, treat the diabetes, make a better control of blood sugar, and at the same time treat the bacteriuria also. Coming to the neurogenic bladder, you might be getting a lot of patient having ileal conduit, orthotopic neobladder. They are always having when you do culture or routine examination, there will be bacteria, a lot of clinically significant bacteriuria, but clinically asymptomatic. Patients on CIC, they are always having bacteriuria. So in those cases, don't treat it. What happens if you treat this bacteriuria? The bacteria will go away, but new resistant strain will colonize and will pose a lot of problems. So actually in this population group, the commensal bacteria, which are intestinal bacteria, are basically protective and prevents further deterioration of renal system and breakthrough infections. Remember, asymptomatic bacteriuria doesn't damage the kidney. Our prime target is to prevent the damage of kidney and the upper tract by taking care of the lower tract. So if the asymptomatic bacteriuria is not damaging the upper tract, we don't have to treat the lower tract as far as asymptomatic bacteriuria is concerned. Again, indwelling catheter and stent. So when you put a catheter, if a person is having a catheter for 15 or 20 days, 100% chance of bacteriuria, 10% per day of catheterization. If a patient is catheterized for more than 10 days, the bacteriuria is 100%. So what will happen? We don't have to treat it. We will never be able to eradicate the bacteria. There must be some bacteria all the time. Moreover, the infections are of mixed variety only. So if you treat one type, there would be a natural selection of other type of bacteria which might be resistant, which might not get treatment later on. So don't take the protection of having asymptomatic bacteriuria from these patients. For urethral catheter exchange, many times we have to exchange the catheter on monthly basis. So at the time of catheter exchange, just don't do anything. Just take care that you don't have breached the mucosa. It's mucosa which leads the portal for the bacteria into the bloodstream. So just prevent it. Do it in that way only. Treat, do a culture, do culture sensitivity, treat the bacteriuria as per protocol if you do nephrostomy exchange or stent exchange, because these two are potentially bacteremic condition which can lead to sepsis. Coming to the immunocompromised patient, in cases of HIV, when CD4 count is less than 200, in cases of neutropenia, these particular groups are already on some kind of prophylaxis. You don't have to treat. You cannot prevent the breakthrough infection again. Transplant recipient, no benefit, don't treat. Let them become symptomatic, then only treat. Before other surgeries, you might be getting a lot of call from various departments that I am going to have lap cholecystectomy or lap even in urology, lap nephrectomy, and there is a bacteriuria. So that bacteriuria is asymptomatic. You don't have to treat. It doesn't prevent clinical infection. Again, I am repeating, doesn't prevent clinically symptomatic infection. No need to treat. Before urological surgeries, based on mucosal breach, if you do if you going to do TURBT where you breach the mucosa, you have to treat the culture. If you are going to lap nephrectomy, you are not entering into the mucosa, you are not entering into the urinary tract, just don't treat. Asymptomatic bacteria, don't you overuse the antibiotic. Recurrent urinary tract infection, don't treat. Recurrent infection, when you treat, some other resistant strain will colonize because they have the genetics. They have the tract which can always be colonized by some or other bacteria. If you treat, some harmful bacteria might get colonized and will lead trouble to the upper tract, which is of paramount importance to all of us. Now I'll discuss one or two clinically significant condition because most of the things I have taken care. So a few slides for that. One of them is emphysematous pyelonephritis. Remember the triad. If you see female patient, diabetic, particularly with some form of obstruction, most of the time you will get a stone, and the obstruction is present in 20% cases, not necessary. If you get diabetic women of 30 year, 40 year, 55 year, 60 year, whatever, with fever, flank pain, that is for pyelonephritis thing, fever and flank pain, but it has associated vomiting on it. What will you do? Try to think it could be emphysematous pyelonephritis. It is caused by gas forming bacteria. It is a acute necrotizing infection which leads to destruction of parenchyma and gases and liquids everywhere. It is a urological emergency. So how to manage these cases? Wang and Singh proposed his mechanism. I'll not get into the detail of that, already taught by another speaker. I'll just tell you, don't go into the detail of those 4 classification. Just do a CT scan, that is must. You don't make diagnosis on ultrasound and X-ray and suggestive of this and that. No, you do CT scan, good quality CT scan. You see all the images, try to find out how much is the gas and how much is the liquid, because it is directly related to the mortality. So if you see lot of destruction of parenchyma, lot of gases, lot of gases, the chance of mortality and chance of saving the kidney is very less. Again, if you see lot of liquid and less gases, less gases, the chance to have chance of survival is high. 20 chance of mortality is only 20%. But in that case, when there is destruction, there is more gas, mortality is 60%. So what will you do? You just try to focus on the packets of liquids and the amount of gas. You also see the pattern of gas. Mottled means irregular, no shape size. So if you see the mottled pattern, remember the kidney is probably more at danger than those emphysematous cases when the liquid is prevalent. So what are the options? You do PCN. If unilateral, do unilateral PCN. If bilateral, do bilateral PCN. If you provide broad spectrum antibiotic, whatever you can give, you give antibiotic based empirically first, then you do culture, change it to the narrow spectrum, do nuclear scan. If you see the kidney is still functioning, keep the kidney, otherwise do nephrectomy to save the life. Sometimes you might have to do nephrectomy. However, in the today's era of higher advanced antimicrobial era, we are able to save most of the kidneys in this particular category also. Just remember 4 factors: thrombocytopenia, serum creatinine, altered sodium, and shock. If two or more of them are on the bad side, the chances of mortality are high. So just remember these prognostic factors for emphysematous pyelonephritis. Again, another group is catheter associated urinary tract infection. You might be having in your hospital setting most of the time patient admitted in ortho ward, medicine ward, surgery ward for long-term catheterization, again for so long, and what happens? There is bacteriuria. A lot of calls you might be getting that patient is having irritation. So I got this culture done, and this bacteria is present. So we'll start with the definition. Definition is, if the person is hospitalized and has developed bacteriuria after 48 hour of hospitalization, or if the patient is discharged and has developed this symptom within 48 hours of discharge, it is hospital acquired urinary tract infection. Remember, 20% of all acquired infections are because of urinary tract, and 10% of them dies because of this septicemia related to urinary tract infection. So duration of catheterization is most important factor here. Again, I told you 10% each day. Just calculate. How will we diagnose? To make a diagnosis, do first thing, take the catheter out first, insert a new catheter and send the culture. Don't send the culture from the catheter which is already there. So take the catheter out, put a new catheter, take the urine sample, send the culture. If the culture is more than 1,000 colony forming unit per ml, plus at least one sign of UTI or one worsening sign of UTI, like new developed fever or fever worsening, dysuria, urgency frequency, etc., any new thing is developing or worsening, it is catheter associated urinary tract infection. It is a hospital acquired thing. How to manage and prevent? So how to manage and prevent again? Remember, prevention is better than cure, age old proverb. So again, whenever you insert a catheter, maintain a sterile technique, especially in hospital setting. Please maintain it. Don't let anything open, like catheter end open, urobag, drainage bag is open. Make it a closed system. It prevents itself a lot of infection. Treat as complicated UTI because it has been acquired in hospital, so it has to be a complicated UTI. So just treat in that way only. Change the catheter before the start of antibiotic. Now again, you have to put the, because you have to treat it like a complicated UTI. So what will you do? First, take out the catheter. I already told you, put a new catheter, start treating as a complicated UTI with IV antibiotics and stop antibiotic. As soon as the symptom goes, don't continue antibiotic for more than 2 days. If it is asymptomatic, already told you, don't treat. Teach catheter care. It includes washing of penile tip with water or normal saline. Don't use any antiseptic cream, any soap, any detergent, any betadine. Please don't use. Now because the infection and prevention is the need of the time, and it has led to a lot of discussion regarding what will happen in future when we will run out of all antibiotics. Concept of emergence of resistance of antibiotics has started long ago, and now we are here. This is an article in 2003 only. Emerging antibiotic resistance in urinary tract pathogens. It was published in Infectious Disease of Clinics of North America 2003. At that time only, it was observed that strains are already resistant to trimethoprim and sulfa drugs, already resistant to beta-lactams. But the most worrisome part was that the resistance has been developing very fastly against the fluoroquinolones. Then again, we had a paper from European Journal of Pediatrics. They actually took the culture from a hospitalized pediatric group. Most of them were having definitely some complicated UTI because of abnormal anatomy of the urinary tract. More than 3,000 patients, more than 4,500 samples. What did they find? They find resistance to nitrofurantoin and phosphomycin was not frequent. However, the most of the time, E. coli were already resistant to amoxiclav, cefuroxime, and quinolones. This was the article in 2016. 13 years, what was thought in 2003 is a reality now. In 2019, again, article was published in Pediatric Clinical North America, and this again showed that the rate of resistance is alarming. It is soon going to be a healthcare threat, public health threat. In 2018, another article in Pediatric International from Chinese group, and they showed in hospitalized pediatric patient, more than 80% resistance found against E. coli of which antibiotics which we used commonly: penicillin, cephalosporin, quinolones, trimethoprim and sulfamethoxazole, even third generation cephalosporin. 80% of hospitalized were resistant. So it is a high time now to get into this, and we start using antibiotic judiciously. Now this is the latest article from Journal of Clinical Microbiology, published from a group from Singapore, and what it stated that there is more than 20% resistance to ciprofloxacin and cotrimoxazole in which setting? Primary care setting. That means this is a community prevalence of resistance. People at the primary care comes from directly from the community, tertiary care hospitalized. But understand, this is the scenario. On multivariate analysis, especially Indian people and diabetes were independent predictor of resistance. So we Indian need to think over it more than anybody else. So what is the problem? Problem is unauthorized use. Unauthorized use means we either overuse or we use underuse. Overuse means we are giving antibiotic that is not necessary for long duration of time. Underuse means we are not treating it sufficiently. There are pattern at peripheral level that people have been prescribed antibiotic for 5 days for a UTI in men, and he will take for 2 days only, and then get corrected, and 6 months later he come with another episode of infection with resistant organism. So this is unauthorized use. Please adhere to the guidelines, national, international, and local guidelines at the hospital level. Non-adherence, duration and dose is very important. Appropriate duration and only appropriate dose. Do not overuse. A lot of treatment were not actually required. A study found that 20 to 50% of cases were overtreated. They actually were not required any treatment and could have been become bacteria free on itself by simple lifestyle modification. Ignoring ecological impact and collateral damage. So what is ecological impact? When you prescribe antibiotic, there is adverse effect not to the patient but other adverse effect like selection of multi-drug resistant strains. You do a lot of antibiotic, you kill E. coli, and then you get Proteus, you get Pseudomonas. So this is collateral damage, ecological impact and collateral damage. So you have to take care of that. So how does ecology gets affected? How the resistance develops? One is intrinsic resistance. You cannot do anything because you don't have antibiotic against the mechanism which leads bacteria to become resistant. So you cannot do anything. In those cases, you have to remove that organ. If there is kidney that is infected and you don't have any bacteria, you have waited sufficiently, patient condition deteriorating, you just take out the kidney, make the patient symptom free, or at least provide some life. Acquired condition, development of resistance. Next is acquired resistance. Acquired can be chromosomal or plasmid mediated. Chromosomal occurs when you prescribe medicine but you don't prescribe medicine which has a urinary concentration which can kill the bacteria. So if you are treating complicated UTI, or if you are treating pyelonephritis, and if you use nitrofurantoin, it will not kill the bacteria. So what will happen? There would be reinfection with resistant strains. But in our part, what is most important and what is most devastating, that Enterobacteriaceae develops plasmid mediated resistance. Most of the UTI resistance is plasmid mediated, which can be transmitted to other species, which can be transmitted to other genera. Klebsiella resistant can transmit this plasmid mediated resistant to Proteus, to Klebsiella. So this thing is particularly important for the multi-drug resistance. This happens 5 to 10% of times, and 5 to 10% time is not less. So what to get rid of this? Or get rid of this? How will you do this? So what are the guidelines and what are the Lancet Infectious Disease Analysis told us? That follow the guidelines for prophylaxis and treatment. Whatever national, international, or local guidelines are there, whatever the antibiotic microorganism infection pattern is there in your area, do that thing only. Suppose if your area has a resistance pattern of less than 10% for quinolones, you can use quinolones well. But if it is more than 10%, so how will you come to know? If you treat 200 patient or 100 patient in a year of clinically symptomatic urinary tract infection, and if you see that 15 of them are resistant to quinolone, resistance is more than 10%. Please don't use quinolones in those areas. How will you select antibiotic which MIC is more than killing, that is available in urinary tract infection? There are MIC tables which you can get. You keep on your table in your OPD. You get the culture done. You match the antibiotic. Which are the antibiotics? Suppose the bacteria is sensitive to nitrofurantoin and cefotaxime also, but cefotaxime has a higher MIC for the same bacteria that cannot be achieved in urinary tract. Go for nitrofurantoin, because nitrofurantoin is relatively more excreted in urine and it can kill the bacteria. So it is not always higher. Select the antibiotic which has MIC concentration in urinary tract higher than the MIC of that bacteria. Adhere to the guidelines. Remember this, you have to be very particular about that. Measure to text your adherence to the guidelines. These are the two main component of antibiotic stewardship already told. So what is this stewardship? Adhere to the guideline, and there is one tool which will let you, or which will make you, which will compel you to adhere to that guideline. So remember this, what is the goal of this antibiotic stewardship? Treat the patient, optimize the outcome, means cost effectiveness, resistance, healthcare infection. Remember, there is a tool to evaluate this antibiotic stewardship also. This is a global initiative. More than 135 centers world over is doing this, including India, in more than 50 countries. It has been analyzed in 2016 Lancet study, and it was found that 35% reduction in relative reduction in mortality if we adhere strictly to the antibiotic stewardship, because of lesser resistance and lesser multi-drug resistance. So thank you all from AIIMS Patna. Dr. Vijay, you can take over.
Thank you, Dr. Kamlesh. That was a very comprehensive presentation regarding antibiotic resistance and treatment in special scenarios. So I think you have drove home the 2 points very well, that rampant antibiotic misuse has led to a big problem first. And secondly, I think now everybody agrees that fluoroquinolones are now not the first choice for empiric therapy. And now I think we have to go back to nitrofurantoin, or maybe now you start to use phosphomycin as the empiric first line therapy, because now fluoroquinolones everywhere are showing high resistance. And if this continues in all areas, then we are going to have a big problem. And not only urologists, but I think all people who are treating UTI in the community, that is general physicians and general surgeons, we all have this responsibility to treat the UTI well for appropriate time and counsel the patient well, obtain a culture so that these patients don't keep recurring with UTIs, have their upper tracts damaged. So thank you for that presentation, Dr. Kamlesh. And now I will invite Dr. Kamaljeet Singh Kaura, who is from AIIMS Bhatinda. He is working as assistant professor in urology, and he will be talking about current concepts of UTI prophylaxis and novel UTI biomarkers. So Dr. Kamaljeet, please.
Yeah, thank you very much, sir. Good evening, all. Let me share my screen.
Yes.
Yeah.
Yeah.
I'll be talking about a very interesting topic as such, which we usually in these days we are coming across in our OPDs. That is concepts of UTI prophylaxis and novel UTI biomarkers. And
can you please full screen your presentation?
Yeah.
Slide. Okay, fine. Thank you.
Right. Yeah, I'll be discussing this topic in two parts. First, I'll be taking up novel biomarkers for recurrent UTIs, and second part will be the concepts of UTI prophylaxis that are currently there. Let me take up biomarkers first, because they are not the routine things that we are dealing with in our OPD practice. Now, why there is a need for biomarkers in UTI? We know the risk factors are there. Many risk factors are there for recurrent UTIs, and clinically, when a patient present to us, in many cases in recurrent UTIs, there may not be identified risk factors there. So the objective why we need biomarkers is that we need biomarkers to predict the recurrence risk in these patients if once they have a first urinary episode. So we should make out that there is a risk of recurrent UTI, and we can manage it accordingly. In animal and human studies, a lot of biomarkers have been studied, and I just made this table to have a summary of biomarkers that I'll be just dealing in next few slides. So they can be broadly classified into serum and urine biomarkers. In serum, we deal with the different biomarkers like granulocyte, corneocyte, stimulating factor, macrophage, CSF, interleukins, antibodies, PSA, vitamin D. And in urine, routinely we check for nerve growth factor and neutrophil gelatinous assured lipocalcin along with interleukin. Just quickly, I'll just go through because it's more of theoretical part. So I'll just quickly go through this. So first of all, serum antibodies. These include IgG, IgM, and IgA. These were possibly the first biomarkers that were studied in recurrent UTIs. There was a study in 2001 by Suman et al., in which a woman with recurrent UTIs who had complete antibiotic therapy were recruited, and they showed a significantly higher levels of serum antibodies compared to the healthy controls. So next biomarkers is granulocyte coronocyte stimulating factor, macrophage CSF, and interleukins. This was the first study was done in 2010 by Hanan et al., in which they investigated serum cytokines in mice with acute bacterial cystitis, and the levels of serum hormone, the CSF, and interleukins at the onset was significantly higher in this animal study. The research group then further investigated these cytokines in women with uncomplicated cystitis and tried to identify the biomarkers from 48 different cytokines. So this macrophage CSF was ultimately found to be significantly elevated in these recurrent UTIs. Another interesting fact is serum PSA levels. Normally, we are routinely talking about PSA in our CA prostate patients or BPH patients when their levels rise. But in a few studies, it is found that male patients with PSA levels higher than 4 at UTI onset were less likely to have recurrent episodes compared to those with PSA levels less than 4. Similarly, the vitamin D levels, the deficiency of serum vitamin D levels might act as a biomarker for recurrent UTI. Vitamin D, we know, is associated with all the body mechanisms. Similarly, it is in UTI also. The importance for innate immunity by increasing the importance is that vitamin D is important for innate immunity by increasing the neutrophilic phagocytic function. So there was a study in 2013 by International Journal of Infectious Diseases in which they measured the mean serum levels of vitamin D among premenopausal women, and they found that these with the recurrent UTIs, they had the lower levels compared to the controls. So that's enough about the serum biomarkers. Now let's have a few slides regarding urinary biomarkers. NGF, nerve growth factor, is the first that we can study, and this is a small protein that induces the survival and differentiation of neurons. So it is seen that urinary NGF levels are significantly higher in women with recurrent UTIs. So it was found in a study in International Urology Journal in 2016, in which a prospective study was done on uncomplicated UTIs in women, and they found that the serial urinary NGF levels in women with recurrence were lower than those without recurrence. Similarly, NGAL, neutrophil gelatinase associated lipocalcin. This is an iron transporting protein, which is a promising biomarker, usually studied with acute kidney injury. But there was a study by Foster et al., in which they found that in young patients with first UTI recurrence, these urinary NGL levels were significantly decreased, probably due to reduced expression of TLR4. And another urinary biomarker is urinary interleukin 8. These levels might have a predictive value in recurrence of UTIs in women, as was found in a study in 2009. This was a cross-sectional survey in which they found that these cytokines in recurrent UTI in women were raised compared to the controls. Now, what about the guidelines? What do the guidelines say about these biomarkers? Frankly, there is no mention of biomarkers in predicting the recurrence of urinary tract in current guidelines. Even the standard textbook, they are not mentioning. So it's probably still the biomarkers are in the research phase, and in future we may see some of these coming into the clinical scenarios and routine practice. So let me take up my second part of my topic, that is the current concepts of prophylaxis in recurrent UTI infection, recurrent UTIs. Now, I'll start with the common perception, or I can say myth or perception, that routinely we have in our mind that prophylaxis always in UTI means antibiotic prophylaxis in different regimes. No, that's actually not true. The prophylaxis for recurrent UTI, I have broadly divided for discussion into two parts. It is number one, antimicrobial, number two, antimicrobial, and superimposing on these is behavioral modification and avoidance of risk factors. Frankly, if you see the guidelines, clear cut, the first thing that is there in European guidelines, that upfront in recurrent UTI patients, we have to discuss with the patient the behavioral modification and avoidance of risk factors. Following which, the second step is about non-antimicrobial prophylaxis, and once these two steps they fail, then antimicrobial prophylaxis comes at a number third place. So these are the three headings I'll be discussing the UTI prophylaxis. I would like to take this chart. This is a very good chart in Campbell urology. This is clear cut what in the last slide I have depicted, that upfront when a patient is having recurrent UTI, the last speakers have clearly described that recurrent UTI can be due to two reasons. One is bacteria persistence, and another is reinfection when there is another strain which is infecting the urinary tract. This is the reinfection part, which is a target for UTI prophylaxis regimes in this case. So upfront behavioral modification, I'll just discuss in the next slide, like hydration and frequent voiding. And after that, non-antimicrobial prophylaxis, I'll discuss few of these, because routinely nowadays we are having in our OPD practices, we are using this, cranberry and all. And once these two they fail, then there is a role of different regimes for antimicrobial prophylaxis. As I said, behavioral modification and avoidance of risk factors. My previous speakers have already discussed a lot about risk factors for recurrent UTI, so I won't go into detail. But of course, before prophylaxis, we have to rule out these risk factors and avoid if any of these are, present. A few slides regarding behavioral modification. Clear-cut lack of evidence is there regarding this. So mainly, first thing we can advise the patient is hydration, because it is recommended that hydration augment innate immunity by sloughing of urothelial side and flushing of adherent bacteria. There was a study by Houghton et al. In 2018 in which, in premenopausal women with history of recurrent UTIs, what they found is that when they increase the water intake by 1.5 liter daily, there was a significant decrease in number of cystitis episodes. Secondly, in sexual active young females, they have recurrent UTIs due to sexual intercourse. It is known that sexual activity increases transiently, increases the bacteriuria. So we should guide these ladies regarding frequent emptying of bladder before and after intercourse, because it is seen that this help minimize this progress of transient bacteriuria to symptomatic UTI. Thirdly, we are all aware that spermicide jellies, when some people are using, they decrease the normal vaginal flora, and vaginal pH is altered, and which is a hospitable environment for uropathogenic bacteria. So we should advise the patient to avoid these spermicidal agents. Now the second part, non-antimicrobial prophylaxis. A lot of discussions are going on regarding cranberry. I'll take 6 or 7 one by one. Let me discuss first cranberry prophylaxis. The active ingredient in cranberry is polyphenol type A proanthocyanidin. This is called PAC, which prevents the P. fembri of E. coli from adhering to uroepithelial cells. So primarily, adhesion of bacteria is disturbed. We have this preparation available in many varieties like juice, concentrate, capsules, tablets, extracts. We know everything. We have this in OPD practice. We're prescribing the patients. A few of the important things I want to highlight. The side effects. GI side effects are the ones which are routinely told about this, but in the studies it is found that these were no higher in those who took cranberry products compared to placebo, although compliance rates were less. There was initially, when it was launched a few years back, there was clear-cut warning regarding interaction of this drug with warfarin. But now in the recent papers, this pre-existing FDA warning in which it was said to avoid cranberries in patient taken warfarin due to risk of bleeding, it has been removed, and now these can be safely used with the warfarin taking patients also. What about dose? There have been different studies on 36 milligram PAC equivalent per day as well as 72, and it is found that 72 is better or more effective than 36. Since this anti-adhesion effect, it's an anti-adhesion molecule, this is a short term, so we need these PAC equivalents BD in a BD dose. Yeah. Just a few evidence-based analysis about this cranberry. In 2008, a Cochrane review was done of 10 studies around 1,000 patients were investigated, and it was found that cranberry was effective in reducing the incidence of recurrent UTI in women as compared to older women or people who had catheterization. This was significantly reduced episodes at 1 year, they found, and although side effects were minimal, dropout rate was high, particularly in those who were taking juice. Then there was a Cochrane review in 2012, but in contrast to the earlier review, the second data, they reported that cranberry supplementation did not significantly reduce the symptomatic UTI rate overall in compared to placebo and other things. And when subgroup analysis was done, cranberry did not significantly reduce the recurrence of UTI in any group, including women with history of recurrent UTIs, a contradictory finding in the previous review. Thus, authors did acknowledge, although they acknowledged that the studies were incomplete, but based on these contrast reviews, the cranberry juice currently is not recommended exactly for the prevention of recurrent UTIs. Now, 2017, there was another review on these cranberry products, and a subgroup analysis determined that subjects with a history of recurrent UTI and those with undergoing gynecological surgery benefited the most. But the guidelines, what they say now, because of these contradictory results, current guidelines, they clearly said that on the daily basis consumption, no recommendation on the daily consumption of cranberry products currently can be made. So this is a clear-cut scenario, and I don't know how many of we are routinely using. We can discuss after my presentation. Now, secondly, hormone replacement prophylaxis, which is very common in postmenopausal women presenting with a recurrent UTI. I have started with this recommendation of EAU, the use of vaginal estrogen replacement in postmenopausal women to prevent recurrent UTI is a weak recommendation as per EAU. So, in postmenopausal, just a quick review that what happens in postmenopausal women. We know that there's a decreased estrogen level that contributes to transformation of atrophic vaginal epithelium, which increases the vaginal pH and creates a more hospitable environment for bacteria to thrive. And there is a changes in microflora of vagina, which include loss of lactobacilli and increase E. coli. The residual urine also can have an impact on that. A Cochrane review was done in 2008, in which it was found that vaginal estrogen was more effective in recurrent UTIs, and beneficial effects may take at least 12 weeks to infest. Although the adverse effects were breast tenderness, non-physiological discharge, vaginal bleeding, irritation, itching, burning, etc. There was a concern regarding fracture risk, breast cancer, and other risk cancers and cardiovascular diseases, but no current studies are there who clearly depict that it's there. Just a few lines regarding Mona Lisa touch laser. I just found it very new to me. This is an alternative to this in postmenopausal woman, an alternative to vaginal estrogen therapy, in which it is basically to treat the symptom associated with atrophic mucosa. So this was new, so just I mentioned a line about that. The third non-antimicrobial prophylaxis is probiotics. This is very interesting also because these are the things which we're listening in our OPDs routinely nowadays. The urogenital flora of healthy premenopausal woman is dominated mostly by lactobacilli, we all know. In 1988, there was a study which revealed that intravaginal lactobacilli in administration twice weekly could reduce the recurrent UTI episodes. Initially, it was done on lactobacilli GC and the lactobacilli KCI, but recently the target focuses lactobacilli crispatus and rhamnosus and reuteri. Although some studies showed promising results initially, but pooled data from meta-analysis showed no convincing benefit of lactobacilli. This is clearly what is there in 2015 Cochrane review, and the conclusion is that probiotics cannot be recommended currently as an effective strategy for the prevention of recurrent UTIs. A few lines about prophylaxis of methenamine prophylaxis. These are 70 to 90% renal excreted and convert to ammonia and formaldehyde. And formaldehyde is bactericidal or bacteriostatic depending upon the concentration. Usually we give vitamin C along with this to have an acidification. Two formulations, hippurate and mandylate are there. And contraindications are there: creatinine clearance less than 50, severe liver disease, hypersensitivity, and sulfonamides, acids, and carbonic anhydrates. Now, just a final line that in the Cochrane reviews, it is found that in patients who had normal urinary tracts and did not have catheters, in situ, the short-term therapy with this methenamine contributed to a reduction in symptomatic infections. However, there was a risk that formaldehyde may cause cancers apart from urothelial cancer. So it is still not recommended currently. D-mannose, again, it's a simple sugar which shows the promise recently in bacterial, preventing the bacterial adhesion because it binds and blocks H. fimri of type 1 pili of E. coli. It is as efficacious as nitrofurantoin in the studies, lower side effects, and reduces symptoms as shared with acute cystitis, but still not recommended. Just a few lines about vaccines. Immunoactive agent prophylaxis. One of the possible pathogenesis in recurrent UTI is adaptive immune response dysfunction, especially in the defects of pathogen recognition. Thus, using a vaccine to strengthen the active acquired immunity against uropathogens might be a reasonable prevention. This is the pathophysiology behind this. The trials have been started since 1994. Both oral and parenteral vaccines can be there. Just a few lines about both. The oral vaccine is called Urovaxam or OM89. This extract that contains 18 serotypes of heat-killed uropathogenic E. coli, and these serotypes increase neutrophils and macrophage phagocytosis and stimulates the immune system of the host. The meta-analysis was done in 2013, and they found that risk ratio of developing at least one UTI was lower in this oral vaccines group. But adverse effects were also equally common, and headaches and GI were most frequently used to adverse effects. And they emphasize the need for future studies because still the evidence is lacking. But if you go for EAU guidelines, they clearly said that the use of immunoactive prophylaxis to reduce recurrent UTI in all age groups should be recommended strongly. This is a bit strange thing with lack of evidence currently. Another vaccine is vaginal vaccine. The name is Urovac. Again, it works via stimulating IgA and IgG in urinary tract and subsequently decreasing the potential colonization of the bacteria. Contain 10 heat-killed bacteria, and there were trials which have showed that meta-analysis have showed that Urovac slightly reduced the these recurrent UTI rates, but EAU recommendation is there. Now, final 3-4 slides regarding the antibiotic prophylaxis. Antibiotics, what are the routine antibiotics already have been taken by previous speakers. I'll just start directly with EAU 2020 guidelines. Clearly mentioned that it is mandatory to offer antibiotic prophylaxis after counseling the patient for side effects, after behavioral modification and non-antimicrobial measures have been unsuccessful. It's very clear that it is not the first line prophylaxis, it's the third line basically. And the EAU recommendation again says that use continuous or postcoital antimicrobial prophylaxis to prevent recurrent UTI when other interventions are failed, and counsel regarding the side effects, the same thing that I told. Just a table, just a summary. What are the 3 types or 3 regimes of this antimicrobial prophylaxis? We can use it continuous low dose prophylaxis or postcoital or self-start. In continuous low dose, the options that we are currently having is nitrofurantoin 50 or 100, phosphomycin 3 gram every 10 days repeated, trimethoprim 100 OD, cephalexin, cefaclor in pregnant ladies, and fluoroquinolones can be used but the least preferred. Continuous antibiotic prophylaxis I'll take on next slide. So this is mainly continued for 3 to 6 months. Postcoital antibiotic, single dose within 2 hours of coitus in those in which the direct correlation between the recurrent UTI and coitus is established. Nitrofurantoin is preferred drug in this case, although this Septran and cephalexin can be used also. And third is self-start therapy. I'll take up in detail. Fluoroquinolone is most preferred in this, in which the patient self-starts this therapy for 3 days. Just a few slides regarding continuous antibiotic prophylaxis. It's a daily prophylaxis with low dose. Concept is that this strategy, particular antibiotics, they eradicate the pathogenic bacteria from interosseous and bowel without bacterial resistance. Duration is 6 months to 1 year, but in 2004, a Cochrane review was done in non-pregnant ladies. It concluded that women with uncomplicated recurrent UTIs are less likely to have infection if they take prophylaxis antibiotics. So this was in favor. This was the review which was in favor of this antibiotic prophylaxis. And the authors concluded that this continuous antibiotic use did decrease the clinical and microbiological recurrence rate. However, adverse effects were there.
Dr. Kamalji, extremely sorry to interrupt, but we are just running behind schedule actually.
Sir, 2 slides, only 2 slides. Last 2 slides were there. So I just want to highlight the European Association of Urology guidelines. They clearly state that there is a need for reconsidering the long-term antibiotic prophylaxis in recurrent UTI and assess in each individual the alternate preventive measures. Postcoital antibiotic already told that should be taken within 2 hours if the relation is clear. Ideally, prior culture sensitivity should be done. Nitrofurantoin is the most popular and routinely used, but side effects should be explained to the patient. Cell start therapy initially started with the concept that patient, when has the symptoms, started this therapy on its own for 3 days. But later on, patients have misused, and as the previous speaker said, that the concept of antibiotic stewardship has been, rendered ineffective by this use. So there is current consensus that we should not allow this to the patient. But if you allow this to the patient, explain the patient that to use it after the culture results are there, and before that he should start with these, alkalizers and local. This consultation should be as per the local antibiograms. Thank you. Yeah, I am done. Thank you.
Okay. Thank you, Dr. Kamalji. That was a comprehensive presentation, and we may see some of these novel biomarkers making their way into routine clinical practice in few years to come. So now, just before we go to the discussion of cases, I would like to take few audience questions, and the first question is from Dr. Tushar Kanti Mandal, and Dr. Deepak, can you take this question? Dr. Deepak.
Yeah, tell.
The question is that what is the cause of IUGR in asymptomatic bacteriuria, intrauterine growth retardation, and is it mandatory to treat in all cases, and what is the mode of treatment?
Yes, it is seen in pregnancy asymptomatic bacteria cause preterm delivery, and IUGR. The cause is not elucidated. And it is mandatory to treat. The evidence shows that, and you start from lower antibiotic, which is pregnancy safe, and start it and accelerate it according to culture sensitivity. And if you cannot eradicate the bacteria, then give low dose prophylaxis of the antibiotic for that asymptomatic bacteria till the delivery.
Okay, so Dr.
Can I add?
Yes, please, Dr. Shiv, please add to this.
Yeah, hello.
Yes, yes.
Yeah, the cause of IUGR in asymptomatic bacteria is there is immunological response which causes cytokines and inflammatory cells to recruit. That causes harmful environment for the growth of the fetus. That is the cause of IUGR. Why we need treatment of asymptomatic bacteria? There are two causes. First, adverse effect on the developing fetus, and second one is it leads to development of symptomatic UTI and pyelonephritis, which is more dangerous to the females. So it needs treatment in cases of asymptomatic bacteria also, in two conditions, in the pregnancy or in the patient needing any urological procedures.
Okay. Thank you, Dr. Shiv. Also, so I think that answers the question. The main risk of acute pyelonephritis leading to growth retardation. So we need to treat asymptomatic bacteriuria in pregnancy. So next question is from Nashwan, and Dr. Kamlesh, can you please take this question? Dr. Kamlesh, are you there?
Yeah, I'm there. What is the question?
Yeah, the question is, what about males who have cystitis with culture showing E. coli sensitive only to nitrofurantoin and carbapenem?
So I just like to have some more information. Patient has to be categorized into on the basis of whether the infection is upper tract or lower tract. Number one. Number two, symptomatic, asymptomatic. If symptomatic, needs hospitalization or don't need hospitalization. Suppose in worst scenario, when a patient needs hospitalization, in worst scenario, if a patient needs hospitalization having febrile illness, only sensitive to nitrofurantoin and carbapenems, go with carbapenem first, make the patient afebrile, and then continue the treatment till 14 days with nitrofurantoin. This should be the approach. if it is the most devastating condition. Otherwise, treat as per the merit of the case.
Okay. So good.
Suppose it is
Regarding
yes.
inpatient or outpatient treatment, if patient is sick, then we have to go for carbon. Else we can try the
Yes, yes.
Okay, so next question, Dr. Kamaljeet, can you please take this question? This is from
Yeah.
Adnan Yahi, and he has asked that if the urine culture shows all resistance of to all agents, then what should we do?
If the urine culture show all resistance, first of all, we have to see what is the cause of resistance to all the antibiotics. Probably that patient, the antibiotic has been misused, or that patient might have repeated episodes of incomplete antibiotic use. So first of all, we have to see the local antibiogram, why this is positive. And I think if it is all positive, we should discuss with the microbiologist. And there are two possibilities also. We know that all the labs are not taking cultures of all the antibiotics, and we may discuss with the microbiologist that if we have other option left, and if we get it and we can use it. Otherwise, it's a very drastic and very difficult condition, I feel, when you have no antibiotic to put to the patient. Yeah.
I agree. I think the microbiologist help has to be sought, and maybe some uncommonly used antibiotics might have to be given. So next question, Dr. Shiv, can you please take this question? It is from Dr.
Vijay,
SG.
your sound is not coming good.
Yes.
Please,
Can you hear me, Dr. Shiv?
please stay with mic.
Hello, Dr. Shiv.
Hi.
Hello.
Yeah. Can you please take this next question from Dr. SG Sethi, who is asking that after passing urine, some patients feel that evacuation is not complete and patient does pass few drops of urine, and ultrasound is not showing any residual urine. So what is the cause and what to be done for this?
What is the age of the patient?
They have not specified the age, but I think
Okay. So it depends on the age of the patient, because the incomplete evacuation is maybe the one of the presenting feature of the obstructed pathology. In the older age, it's most common due to BPS. In younger age, it's commonly seen in stricture diseases. So in older age patients, incomplete evacuation is one of the presenting feature of BPS. He needs evaluation by a urologist in form of digital rectal examination and ultrasound assessment of the prostate with urofluorimetry.
Thank you. Okay, and one last question, Dr. Deepak Biswal, please take this question. Dr. Rakesh from MKCG is asking, what is the drug of choice for Candida UTI?
Candida UTI mostly seen in diabetic and with catheter or foreign body. If patient is having no symptom, then repeat the culture, or if there is any catheter, then change the catheter, put another catheter under aseptic precaution, and most likely it will subsides. And antifungals have no role until and unless it is very severe infection.
Yes, I think you are right. Anybody wants to add something to Candida UTI, whether it should be treated or treated only with antibiotic? Any other thoughts? Okay. So I think now the audience questions are answered, and now we will move on to a quick discussion on the cases. So I request Dr. Kamlesh to please present the case scenarios and moderate the session. Dr. Kamlesh, please.
So, screen visible?
Yeah, it's visible.
Yes, sir. Yeah.
It's visible. So, as far as cases are concerned, so we will take 4 cases. The first is 28-year woman admitted to emergency with high fever, rigor and chills. At admission, her BP was not recordable. Respiratory rate was 30. She had fever 1 episode 1 month back to settled with cefotaxime for 5 days only. She had a history of flank pain for 2 years on and off, not treated. Some painkillers given, some previous antibiotic uses of levofloxacin and cefotaxime cycles. The question is, why fever once again, and when it is settled?
Hello.
Hello, am I audible?
Yeah,
Yes,
you
sir.
are audible. This, can I take this question? Hello.
She is a 28-year woman admitted in the emergency with non-recordable BP,
I
fever.
have read. Dr. Kamlesh, I have read the question. Can I answer?
Yeah, sure. Please answer.
So she is currently a case of urosepsis with inadequate treatment of past UTI. So it's a case of bacterial persistence leading to the urosepsis because of inadequate use of antibiotics every time.
Hmm.
So fever is because of urosepsis.
So,
And
Dr. Siv, how to proceed?
so in
Now,
this
patient
case,
is in emergency department in shock. This is
yes,
clear.
yes.
Patient
So
is in
in this,
emergency department in shock.
so
How to
in this
proceed?
case, So in this case, in the emergency, first we have to do vigorous resuscitation in the form of IV fluid channel, followed by inotrope if needed, and broad spectrum antibiotics. And just before that, we have to send the culture for antibiotic sensitivity. There we have to start broad spectrum antibiotic, and after, as soon as culture available, then we have to narrow down the antibiotic spectrum, and we have to use the complete course of antibiotics to ensure the complete clearance or complete eradication of the bacteria.
Dr. Vijay, would you like to add something to it?
So I broadly agree with Dr. Shiv that previously the cultures were not obtained and the unit was not evaluated. The spectrum of fever with flank pain and hypotension suggests urosepsis. So we have to start empiric broad spectrum antibiotics. I think a third generation cephalosporin. And before starting, we should send for the culture and change according to the antibiotic culture sensitivity, and also do a imaging, preferably a NCCT. And if there is obstruction, then we have to drain. Else, we have to treat the pyelonephritis and sepsis.
Yes, this patient needs imaging. First ultrasound, and as soon as stable, it needs NCCT KUV.
So basically the conclusion is, because we have to classify it, because this is a complicated UTI, and that is especially in shock. So number one, we have to do the resuscitation within first hour. We have to give broad spectrum antibiotic. This is number two. Then we have to use crystalloid oblique albumin as per requirement. If BP is not maintaining, start with NORAD and then do imaging. And before start of antibiotic, send culture sensitivity, do imaging, because there is some obstruction. She had a history of pain, so it might be some obstruction for whatever reason. We have to image, and on the basis of that, we have to drain the source of infection. So probably we have to do some drainage procedure also based on the imaging results. The lady will recover. Should we go to the next question?
Kamlesh, I just want to just add one thing in this case. Can I?
Yeah, sure.
Yeah, similar patient. I just had one very tricky thing. Suppose we add in this patient, similar patient in ICU. You send the RFTs of this patient are deranged. You have a urine culture report with you, which is showing some higher end antibiotics like imipenem or carbapenem, piperacillin sensitive, and you have the counts of this patient 28,000, 30,000. Many a time what happens is we have to give the dose of antibiotics in a titrated manner, low dose, not exactly the dose that we tend to give. So many a times such patients, they don't respond with the repeat your TLC next day and you see it's not responding. Patient is not the fever is not responding. So what about these tricky things? How do you handle these things when you're not giving adequate dose of antibiotic due to deranged RFTs in these tricky patients?
Sir, in most of the time, most of the cases, whenever there is urosepsis, it is almost always associated with some sort of a obstruction or some sort of anatomical problem with the urinary tract. We have to drain the system. So as soon as you drain the system, the count will start settling with whatever antibiotic in adjusted dosage. you have. So imaging is that's why imaging is very important here. Once I'm sure you have gotten these kind of patients, there must be some sort of obstruction at some level, lower urinary tract, bladder dysfunction, VUR, or mega ureter or stone, most commonly PUJ obstruction. Some sort of obstruction is there, and as soon as you put in a nephrostomy tube or you do double J stenting, it is most of the time settled with whatever antibiotic you have, and the creatinine comes down in coming days. Isn't it true?
Yeah, yeah. Yes, that is there. But sometimes these patients are in shock. They take, 3-4 days to recover. Once you can take probably to a place where you can place an nephrostomy, or you have a, in the ICU setting, you can put a. These are some of the tricky things. You can have the problem in first 48 hours, 72 hours.
Any patient with urosepsis and impending shock, please do not treat at a center when there is no ICU is available. Please give one sort of broad spectrum antibiotic and refer to a center with having ICU facility. One more thing I would like to tell: in the emergency department, do a quick SOFA scoring. Without quick SOFA scoring, we would not be able to tell who will require the ICU care, and in that way we can titrate the patient. We can titrate the care to that patient. Suppose if the respiratory rate is more than 22, systolic BP or mean arterial pressure is less than 100, or systolic BP less than 100, or MAP less than 65, mentation is altered, if anything is present, the patient is bound to deteriorate. And in that case, we have to shift the patient to ICU. We have to talk to the people that is relevant to the microbiology, infectious disease treating personnel like medicine people and anesthesia people. Collectively we can treat. At the same time, we keep doing our job of a urologist. We have sometimes we need to look in other organs also, whether other organs are also contributing in this septicemia and not responding. If we have to take the blood culture, at least 2 blood culture at the same time when we have taken urinary culture. So in this way we can manage. Sometimes it is not possible to handle the patient doing all these things. So organ removal ultimately, if patient permits, might be choice to save the life.
Right, right, absolutely.
Move to next case now.
Coming to the next question, a 35-year woman came to OPD with report of urine culture having E. coli. Culture is significant, that is more than 10 to the power 5, but she is asymptomatic. Had taken multiple course of antibiotic previously for the same. Her culture reports now showing sensitivity to meropenem and imipenem only. So already this kind of thing has been answered. Nitrofurantoin and imipenem for that lady, I guess, that male patient. Somebody has asked that
Yes.
the antibiotic. So I guess we can skip this.
Yes.
So the question is, why this condition? Why this condition? Because of the because of the emergence of resistant strain in that particular patient. How to treat and evaluate? What to advise? Already given. If asymptomatic, don't treat. Question number 3: in hospital setting, what we get: 30-year women hospitalized for 5 days for lab cholecystectomy. Now the women here, the patient is hospitalized for 5 days, more than 48 hours. Remember, a call made to the urology department because of a urine culture report showing E. coli more than 10 to the power 5 CFU per ml. She is known case of rheumatic heart disease, got her mitral valve replaced, then arthritis, got her knee replaced also. Now she has to undergo cholecystectomy. What advice has to be given? The call has been sent to the Euro department to take care of this bacteriuria. What will you do, Dr. Vijay?
So, Dr. Kamlesh, since she is hospitalized for 5 days and E. coli, there is more than 10 raised to 4 CFU per ml along with prosthetic valve and knee prosthesis. So, first of
Keep
all,
your mic closer. Keep your mic closer.
yeah. Okay, so now am I audible? Hello?
Yeah, audible.
I think I will involve the knee specialist and the cardiologist also in our care. And since the catheterization during laparoscopic cholecystectomy will lead to bacteremia, and even transient bacteremia may lead to seeding of the prosthetic mitral valve and knee prosthesis, which is a disastrous scenario for the patient. So here I would like to treat the patient and see whether her cultures come back negative. But if her cultures don't come back negative, so that may mean she has asymptomatic bacteriuria. So I will go ahead with the lab cholecystectomy under a antibiotic cover. But first I will give a trial and see whether the culture comes negative or no.
Okay. So anybody to add to this? Dr. Deepak? Dr. Deepak, are you there?
Yes, yes. He has 2-3 problems. One is she had rheumatic heart disease. Second is he has knee prosthesis, but those are old. The thing of eradication of asymptomatic bacteria is now little controversial. Recent guideline shows even for knee prosthesis, you can skip treating asymptomatic bacteria.
So, in conclusion, what I can suggest that both American Association Heart Association and American Association of Orthopedician has made it very much clear based on RCTs and reviews that neither of these conditions, whether heart valve, whether prosthesis more than 2 years, whether patient is having hospital acquired infection, if in all of these cases she is asymptomatic, we don't have to misuse the antibiotic. Now coming to the case number 4, a 30-year man came to OPD with right flank pain and fever of 38 degrees Celsius. A 30-year man, 5-day course of nitrofurantoin 100 milligram BD was given empirically and culture sent. After the culture came and showed that the bacteria was sensitive to nitrofurantoin. He was all right after the treatment, but again presented with to the emergency department with acute flank pain, fever, rigor, and chills. So again, patient was treated with 5 days of nitrofurantoin for acute pyelonephritis. Now returned again to the emergency department with acute pyelonephritis 1 month later. What is the probability if asymptomatic again develops symptoms? Dr. Deepak.
Yeah, actually in male, first thing is there is inadequate antibacterial therapy. For acute pyelonephritis, you should give it from 10 to 14 days. And after that, there should be, you should repeat the culture if the bacteria in the urine is eradicated or not. The first cause is it is due to inadequate antibacterial therapy.
Dr. Kamaljit, what was the mistake from clinician and how to treat now?
Sir, basically they give nitrofurantoin, which was the urine-specific antibiotic. They should have started with the system-specific antibiotic like fluoroquinolones or cephalosporins, because prostatitis is a component, additionally component, and it was a case of clear-cut pyelonephritis upfront. So again, antibiotic was not properly chosen, and inadequate antibiotic or inadequate duration of antibiotic was also there. So that is the reason in this case.
Dr. Kamlesh, can I add something?
Yeah, Dr. Vijay, please.
Yeah, so I think the message from this case scenario is that the clinical spectrum of flank pain with fever, initial presentation, that is a clinical diagnosis of acute pyelonephritis. And in this case, we have to remember that nitrofurantoin is a good urinary antibiotic, but it has got very less concentration. So if you are suspecting pyelonephritis, you cannot give nitrofurantoin. So there were two mistakes. Either the diagnosis of pyelonephritis was missed, or if it was diagnosed but still the wrong antibiotic was given. Okay, so for acute pyelonephritis, we have to give a antibiotic which will penetrate the tissue, either sensitive antibiotic like fluoroquinolone or a third generation cephalosporin.
So the message is clear that we should use appropriate antibiotic for a adequate duration.
So
Yes.
finally, I can say that whenever you see a patient of urinary tract infection, please adhere to the guideline. These are the common things which comes from periphery to our center. Please, even at the periphery level, please adhere with the guideline. Classify if it is upper tract infection, lower tract infection, complicated, non-complicated, febrile, afebrile, needs hospitalization, do not need hospitalization. Classify and treat accordingly. This is the message. So now this was the fourth and last case. Thank you very much. Dr. Vijay will take over for closing remarks.
Okay. Thank you, Dr. Kamlesh. So we have come to the end of a excellent discussion on dilemmas in managing and the solutions for managing complicated UTIs. I think the message is loud and clear. We have to give the appropriate antibiotic for the appropriate dose and prevent antibiotic misuse. So I want to thank the whole INTAS team, especially Nishant, for hosting this webinar and conducting it well. I also want to thank Dr. Kamalji, Dr. Deepak Biswal, Dr. Kamlesh, and Dr. Shiv Charan Navaria for participating in the interesting discussions. So myself, Dr. Vijay, we all bid goodbye to you. Thank you all for your attention.
Thank you all. Thank you.
Thank you.
Thank
Thank
you.
you.
Thank
Bye.
you. Thank you.
Okay, thank you all. I think we can stop the transmission.